Okay, that looks good. Well, good afternoon, everyone, and welcome to the Case for Data Collection, the LGBTQ people in COVID-19. This is presented by Howard Brown Health and Pride Action Tank. And my name is Kim Hunt. I'm the Executive Director of Pride Action Tank, which is a project of AIDS Foundation Chicago, where I also serve as the Senior Director of Policy and Advocacy Operations. And I use she, her pronouns, and I'm serving as your host or the hostess with the mostest for today's program. Before we get started, I want to remind folks to keep your microphones on mute unless it is your turn to speak. The format today is we're gonna have a speaker and then a panel, and then we're gonna hold the Q&A until the end of the discussion. But as questions pop into your head as people are talking, you should feel free to put them in the chat because my colleagues at Howard Brown are going to be monitoring the chat, and we're going to make sure that we answer as many questions as possible. And I am really excited to be having this timely discussion. As we see, COVID-19 cases are on the rise around the country, including here in Illinois. And we're really fortunate to have our first speaker here to provide some context for today's conversation and a sense of national work related to tracking the impact of COVID on LGBTQ plus people. Scout, who uses he, him pronouns, is the executive director of the National LGBT Cancer Network and the principal investigator of the CDC-funded LGBTQ tobacco-related cancer disparity network. He provides technical assistance for governmental tobacco and cancer-focusing agencies, expanding their reach and engagement with LGBTQ plus populations. He leads a team of specialists who focus on building tools and sharing strategies across state departments of health. Let us welcome Scout to our virtual stage.
Thank you very much, Kim. I appreciate it. I also appreciate kind of having Old Home Week. I used to work at AIDS Foundation of Chicago, and I was at the Brown Elephant, I think, for most of my youth, definitely. I probably still have some of that clothing in my closet right now. And this is something that I'm certainly doing a lot of work on, so are a bunch of other people nationally. So without further ado, I'm gonna share the screen here so that we can flip over to some slides. All right. So first of all, I want to give you a little bit of grounding on where data collection stands in general across the United States. Oh, I'm sorry. First of all, I should tell you who we are. I'm with the National LGBT Cancer Network. We spend a lot of our time educating our own communities about disparities and then advocating within the cancer scene to include us and training a whole bunch of providers. And you can be a member for free if you're interested. Just go here. We've got resources, newsletters. We've got a pretty big online resource library, things like that. And some cool stuff going on. Okay, so now context for where data collection stands nationally. One of the things I want to point out is when I first started to do these kinds of presentations, one of the things that we would bring up with people around the country is that the population of LGBT people in the United States was about the 9 million people, about the equivalent of the population of New Jersey. And so, you know, we would always kind of drive home. Can you imagine if the whole population of New Jersey didn't have civil rights and it was perfectly legal to discriminate against them? But in the years since I've started the presentation, the big thing to note is that the number has really shifted. We're not at 9 million any longer. We're at 14.7 million. So if you want to kind of put that in analogous terms right now, that's the full population of my state, Rhode Island, and New Mexico and Georgia put together. So again, this kind of helps contextualize how many people in this country don't have civil rights right now. But as we look at this shift, we have to remember that it's continuing to change. Just as an example, this is one of the biggest surveillance systems around the country right now. It only does LGB, well, I shouldn't say that. It does do LGBT, but we only have data here on LGB. So I put it in the bi-colors for the flag there. But this is an example of what that big surveillance system, this is for year 2017, showed as far as how many people identified as LGB, and this is adults only. Now take that same exact surveillance system, switch to its youth counterpart for the exact same year, and suddenly the picture gets different. So as we're talking about this population shifting, it's continuing to shift. We are continuing to grow, and it's in an interesting rate. According to the Gallup poll right now, the percent of millennials saying that they're LGBT identified is going up every single year by almost a percentage point. And you see it in the corner of the screen there, 2589. I, of course, had to calculate what year that meant that the whole population would be majority LGBT, and it's the year 2589. So take your vitamins, you got to hold on. That should be fun. But importantly, one of the things we also have to remember is, where does data collection stand for our populations? I took a break from this work for a little while, and I knew that the Behavioral Risk Factor Social Survey, which is that one that I had mentioned related to adults, had the option of collecting data. And I would say one of the things that I thought after my break, and we went back to see how people were doing with this, is I thought that first of all, people would only be collecting sexual orientation, not gender identity. And that's what SOGI is, sexual orientation and gender identity put together. In the data world, that's what it's referred to. And then second of all, I thought that there wouldn't have been a lot of adoption by states. And I was completely wrong. If you see this, you can see that from the year 2008, when only one state, Massachusetts, was collecting SOGI data on this surveillance system, to 2019, where almost 40 states are collecting on this surveillance system, there has been a huge upward arc in the number of states who are collecting SOGI data on the biggest health surveillance system in the country. So in other words, this is quickly becoming normalized. And if you're interested in trans data, especially, or data related to LGBT communities of color or any other subset of LGBT, this is the place to get it, because we're now taking these data and putting them together over years, and suddenly we can dig in deeper and get information we could never see before about subsets. So it's quickly becoming really standardized. So what happens and what does that mean now related when COVID-19 enters the picture? Well, first of all, let's look at where we stand related to our population and whether or not we have reason to believe that we might have a disproportionate impact from COVID-19. And the answer is, on pretty much every front, yes. We have a public health case statement that shows that we are very likely to have higher risk of it, higher risk for economic instability as a result of these, the economic impacts of isolating and the pandemic, also higher risk of isolation and problems related to social isolation and emotional vulnerability as a result. But importantly and profoundly, we have 50% higher smoking rates than non-LGBT people do. And that means that obviously that's a lung depressant, that's a general health depressant, the smoking, and COVID is a pulmonary based virus. So as you can imagine, those two do not go well together. And if you are a smoker, you have a much higher chance of increased problems if you were to get COVID, and likely a higher chance to get COVID in the first place, and then a higher chance of severe COVID and even mortality. We also have an increasing level of underlying health conditions. Many of these are also tied to smoking, but they're tied to other health risk behaviors as well. We know we have barriers getting welcoming healthcare. And we have a much higher rate of working in the service industry, and we have much higher rate. Well, we have higher rates of being lower income than the general population, and also again being hit by the economic instability. So for all these reasons, we're likely to see a health disparity. We're likely to see increased infection rates, increased levels of severe disease and death, and as I had mentioned, also the economic impacts and the social and emotional impacts. I was just actually talking with someone from Trevor Project earlier today. He was saying these last few months have been, or they were saying these last few months have been brutal at the Trevor Project, talking about how our youth are more isolated from the social supports that keep them more stable. And then here's the great slide on what we know is our existing COVID outcomes. Nothing. And one of the things that really frustrates me related to this is that if you understand, the last time we had a pandemic of this magnitude was 100 years ago. That means, and many things have changed, including our surveillance in those 100 years. That means that the lessons to untwine and take apart this pandemic are probably going to be researched for decades to come in the future. So what we are right now suppressing as far as our data collection on a vulnerable population, us, is going to be something that is not just affecting right now, but we can't backfill these data. So we're unfortunately setting in concrete the fact that we won't be able to get this information for potentially decades in the future. And this is at the same time that, as everybody knows, there's been a greatly increased level of awareness related to health disparities. You think health disparities in general are they're often, for the people in the field, they're like an iceberg where too much of it's hidden under the water, and we spend all our time being like, no, look, there's a problem right under the surface there, right? On the other hand, with COVID, particularly with its impact on the indigenous and the Black communities, that has suddenly become the jagged edge of the iceberg that you can see above the waterline. Health disparities are suddenly something that the whole population's understanding now, because for some vulnerable populations, the outcomes after COVID have been so different that they're writ very, very large. They're making headlines. Whatever our outcomes are, we won't make headlines because, again, our data are not being collected. So we've got 3 instances. Where does this stand around the country right now? We've got 3 states who've done some really interesting work to try and change this. The first one was Pennsylvania. Pennsylvania wrote this letter that I actually forgot that we have our brand on too, but they wrote this letter saying, why don't you collect SOGI data for COVID cases? And they wrote it to their governor. And literally over a weekend, they got 26 organizations to sign on to the letter. Then they sent it up to their governor. They worked with their friendly Department of Health secretary, who's trans. And they basically, in a very short period of time, got it changed that Pennsylvania agreed to do sexual orientation and gender identity data collection for testing. Okay, so how did another state go about the exact same thing? California actually already had a law on the book saying that for health information, you needed to collect SOGI data, but for some reason it wasn't being applied to COVID. So Scott Wiener, who's a community member of ours, who's a legislator in California, brought together an emergency bill saying you have to collect it for COVID data too. And he ran around the legislature and got the support for that. And it ended up ultimately being passed legislatively. So now they're going to collect COVID data related to that around the biggest state, California. What was a third way that they went about this in my home state of Rhode Island, which is a very teeny home state where everybody knows each other. The first step wasn't legislatively, it didn't have to do with a letter. We just talked to people. We just did our little magic in Rhode Island and said, hey, what's up? You need to do this. And so they said yes, nicely. So as a result of that, when you go on the COVID testing site, this is the first set of questions you see right here. And they had a little bit of a problem with the questions. Some people were complaining about the way they were constructed at first. And so we worked with them to try and refine them a little bit, make them a little bit better. And these are on so this is the first thing you see on the testing portal for everybody right now. That's 3 states. We don't know of any other states that are collecting the data right now. There are some smaller instances of hospitals collecting the data, absolutely, but not states doing it statewide. So what does that mean we stand kind of overall related to this? 3 things as far as comments. First of all these states are collecting data related to testing. While we anticipate we may have a disparity related to testing, our stronger public health case statement is that we're going to have a disparity related to outcomes. And outcomes are not any information you get with testing data. In order to get outcome data, you need to have your intake form for electronic health records ask if what your sexual orientation and gender identity are. And that's usually hospital by hospital. No state is requiring that anybody collect SOGI data on electronic health records. And that's actually a real problem because that's where we're really likely to find the biggest difference. So we unfortunately got 3 wins in 3 states on the smaller difference area, but we got 0 wins on 0 states as far as actually collecting it where we expect to see the most change. And second of all, as we're starting to get data back here in Rhode Island, and I'm working with the Department of Health around looking at and analyzing it, low compliance level. Not uncommon when you first add a new demographic question to a questionnaire. People have to get used to it first, but also if it's optional, people can choose to skip it. And then third, if we are thinking about really getting these data collected in the place where we want to, which is electronic health records, we know we have to go through the same process we kind of did related to surveillance. And that's do more education of the communities that when you go to a doctor and see them asking SOGI data, that it's good for us and it's a positive thing. And some of your friends or allies have usually fought to get those measures there. Because right now we know that when you put every doctor's office has electronic health records that allows them to do, say, SOGI data collection. They just have to flip a switch and say yes, and they will be able to do it. But unfortunately, changing that is a process that often takes a lot of steps for the hospitals and is very likely to have community complaints. So whenever we try and push forward this idea of actually getting these hospital data that will really tell us the disproportionate impact of COVID, we're going to have to accompany that with more education of our own community members, showing that we want to see those data collection there. You can choose not to answer 100%, no problem. But don't complain to the head of the hospital if they're asking. That's the big thing. And with that, the only last thing I'll say is we are running a survey so people can speak out related to cancer experiences. If you're willing or interested in being a partner to help promote it, we'd really appreciate it. With that, I turn it back over to all the rest of you.
Wow, thank you so much, Scout. We won't make headlines because our data isn't being collected. Man, that says it all. I really appreciate what you shared with us. And I want to remind folks that feel free to add questions to the chat. I know Scout just downloaded a lot of information to us. So if folks need anything clarified or have questions, the chat is the place to put it, and we will get to it towards the end of the program. So now that Scout has laid such a great framework for us, we'll move into our panel of experts who will provide more detail on the challenges and importance of collecting this data. But before we do that, a quick note, Dr. Maya Green was unable to join us today because she is on the front lines addressing the current COVID emergency here in Chicago. So we want to thank Dr. Green for her work. But no worries, we still have an amazing panel for you today. And they'll each speak for about 10 minutes. And like I said, after the end of the panel portion, we'll move into Q&A. So I am going to introduce a panelist, and then they'll speak, and then I'll introduce the next panelist, and so on. So our first speaker is Tammy Martin, uses she, her pronouns. And Tammy is the legislative manager for Equality California and advocates for the organization's legislative and policy priorities in Sacramento, where it's warmer than it is here in Chicago. Previously, Tammy served as co-president of the LGBT Bar Association in DC and worked with the LGBT Research and Communications Project at the Center for American Progress. So let's welcome Tammy.
Thank you. Hi, everybody. As Kim mentioned, my name is Tammy Martin. I'm here on behalf of Equality California, which is California's statewide LGBTQ+ civil rights organization. My colleague, as you've seen in the chat, Andre Wade, is also here today. He is a state director for our Nevada affiliate, Silver State Equality, and is also a great resource. So I'll be kicking us off with some background information, first regarding the landscape in California before COVID, and hopefully all of this will give people in other states something to work with. We've already touched on, and I believe we'll discuss more in a bit, the need for data. So I won't go into too much detail except to say that by the time SB 932, which was our SOGI data bill this year, by the time the bill was being heard in committee, millions of Californians had already been tested for COVID-19, but we didn't know the sexual orientation or gender identity really of a single one. And essentially, all of that data was lost. And because of that, we didn't know, at least not in a measurable way, the degree to which COVID-19 was quietly devastating the LGBTQ+ community. And to the extent that SOGI data was collected, it was done in the context primarily of STD control or HIV through direct interviews by people who know how to conduct culturally competent interviews. And that system was not widespread. But this data, of course, is necessary, not just from an academic perspective, but to ensure that resources are allocated to the appropriate places and people, and that the most effective messengers are deployed to reach and protect vulnerable communities. And there had been a degree of reporting on fatality rates within communities of color, for example, and that was invaluable. At the same time, we felt once again that the LGBTQ plus community was being ignored and erased. And so the devastating impact of this erasure is really all too familiar to anyone who lived through the AIDS crisis and had to endure the pain of losing their loved ones while the government pretty much just looked the other way. So luckily today, we have an LGBTQ caucus and allies in the California legislature. And because of that, we had data law to build upon, including two main predecessor bills that required specific state level departments and agencies to collect voluntarily provided SOGI data anytime that race or ethnicity demographic data was already being collected. And those were important first steps. But what became all too clear during COVID was that state level entities are not the only or perhaps even primary data collection point. So there were missing links in the chain, which I'll return to shortly. And because of the missing links, we still weren't getting the data that we expected. We also have strong allies in the administration and public health officials who are better able to execute their core responsibility of protecting public health generally and the most vulnerable communities. And this led to the Secretary of California Health and Human Services, Dr. Galley, announcing back in July some emergency regulations that required that every healthcare provider who's working with a patient that had one of a list of reportable communicable diseases to report to their local health officer a number of things, including SOGI data, if known. And the if known language was important, which I'll also return to shortly. But for our purposes, everything in the new regulations from Dr. Galley were consistent with the existing regulations, except for the addition, of course, of SOGI data. So in the midst of all of this, our bill comes along, and we introduced in May of this year, so before the regulations were announced. And originally the bill only required SOGI data for COVID cases. And this was for a number of reasons. COVID was, of course, at the front of everyone's mind. We knew COVID data was being collected, but not specific to LGBTQ plus people. And at the time, legislators were under pretty strict orders not to run bills that were not relevant to specific emergencies, such as COVID. But the bill evolved, however, as we dug into the existing framework. And to stay consistent with the existing regulations, rather than having a patchwork of requirements, we expanded the bill to cover all reportable communicable diseases that were already in California regulations. And so that's also consistent with the new ones that Dr. Galley announced. So the scope of requirements in other states might depend on what the existing framework in your state looks like. We got some pressure after the regulations came out to abandon the bill. You know, people said, well, the regulations exist, so you don't really need the bill anymore. But we didn't feel that abandoning the bill was necessary or advisable. The regulations can change sometimes with less public involvement, and codifying the requirements alongside them would provide a little more stability. So we wanted to proceed with that. As Scout mentioned, the bill was ultimately signed. Like the regulations, it went into effect immediately, although implementation is ongoing and a long process. But what were some of the lessons that we learned, and what were some of the challenges? So number one, right off the bat, we knew, like I mentioned, there was a lack of LGBTQ plus cultural competency training for in-person interviewers. And ultimately, I think that's something that would be great to have, but it wasn't achievable in the immediate moment. So we had to build off of the existing framework for how demographic data was already being collected in other contexts instead, which operates primarily through intake processes. So another big challenge was the sheer volume of stakeholders. And this speaks to the challenge that I mentioned of connecting all of the links in the chain, rather than just mandating something at the top, at the state level. And throughout the process, it seemed like there was always a new stakeholder emerging. Some of that was COVID specific, and some of that would have existed regardless. So some stakeholders that you'll have to consider include, of course, your health officers, and then entities at all levels, including state, county, city, and private healthcare entities. There are contractors, there are labs, coroners perhaps, depending on how providers are defined in your state, and more. And a lot of stakeholders means a lot of different patient points of entry, each of which have different intake and registration processes, some of which include SOGI questions, some of which don't, collecting in different ways, et cetera. And, I mentioned labs. So there was the issue of labs, and what we learned from CDPH, the California Department of Public Health, was that the majority of COVID-19 reporting was being done by labs. And for the most part, our understanding is that labs pretty much just process specimens rather than engage in patient intake. So they just report the specimen results along with whatever demographic data they receive from wherever the patient point of entry was. And sometimes the patient point of entry is the lab, but while CDPH had updated their standard form, which healthcare providers use to include SOGI fields, labs don't actually use that form. And so forms are a whole other issue where you have to make sure everyone's either using the same thing or that all the different forms are updated accordingly. The drive-through testing sites also, as we understand it, don't use that form. So the demographic data that exists from that interaction is whatever the patient fills out during their typically online registration process. And those drive-through testing sites are run by various entities. Some are city, some county, and some state. Again, each of which is doing their own thing. And the relationship between the testing site and the governing entity often falls under a contract, of course, with a private party, which may or may not want to change their protocol until the contract is renegotiated. So there's that whole logistical side of things. But the requirement exists, and all of these points that I raise are points for post-passage implementation with the entities running those systems. And then a third challenge was that all of these stakeholders were overwhelmed. We all know that there was a large volume of cases and health systems were overwhelmed with COVID-19 response. And that leads me to the fourth point. So some people have asked if the requirement is retroactive, and the answer right now is no. There was a time when the bill could have been read to be retroactive, and that drew too much opposition because of the immense pressure already on health officers and the perception that retroactivity would completely overload their capacity, and we want to be sensitive to that. And then finally, there was a challenge of what the community thought the bill would do. Data is not the easiest thing to understand. The existing processes are pretty technical. So we found it important to emphasize that just as in existing requirements for other demographic data, SOGI data would only be collected and reported if it was voluntarily provided, which is why the if known language that I mentioned became so important to retain. So no one's going to be forced to out themselves or to respond in any way that is uncomfortable for them. Of course, the big goal is to obtain as much useful data as possible, but the patient really steers in that respect. And we want the patient to be self-identifying rather than having the provider, select an option based on an assumption or a stereotype. So that's important. And then, okay, so moving on to some of the work that's remaining. The bill essentially requires two things. One, it requires that providers, as defined in the regulations, report SOGI data, if known, for specified diseases. And two, electronic reporting tools used by local health officers to report up to the state. Those tools have to have the capacity to collect and report SOGI data, thereby closing the local versus state data gap, because there are different electronic tools that are used. And so we wanted to make sure that whatever you're using, that it has to be updated to do this. And those are great requirements. But really the bulk of the work to execute the goal of the requirements has to be done right now, post-passage. I believe implementation will be covered in more detail as a topic later, but a few things. We're approximately 4 months since the regulations went into effect and about a month and a half since the bill was signed into law. And we still aren't seeing these questions being asked in a widespread way. So we're continuing to push cities and counties to, et cetera, to update their systems. And that is happening. It's happening slowly, but we have the law and we've made the case for why this data is necessary. So it's only a matter of time. And we did just reconvene a diverse group of advocates here in California who want to continue the momentum and explore what's left to be done, including maybe some oversight and accountability, maybe an audit, because half the battle is just understanding how all these different processes are happening, and apply some pressure to make it happen. But of course, as you advocates in other states also make progress, it will contribute to the groundswell of pressure to get this done everywhere So I would love to hear more about how things are going in Pennsylvania, which Scout mentioned, and elsewhere, regarding whether requirements are translating into results and how that looks. But with that, thanks for giving me the opportunity to share some of what we went through in California. I hope to continue working with all of you and learning from all of you to make sure LGBTQ+ folks are accounted for everywhere. I might get pulled into a meeting at the end of this. I'll put my email in the chat. If you have any questions for me, feel free to shoot me an email. Thank you.
Thank you so much, Tammy, for sharing your experiences in California. I know that's going to be so helpful for folks across the U.S. and my interest is Illinois, so you've definitely been a great resource for us as we've wrestled with this. As Tammy mentioned, she may have to duck out a little early, so make sure that you take down her email address in case you have any questions. But if she's here towards the end, we would love for your questions to be presented in the chat so she can answer them here. So our next speaker is Lauren Beach, who uses she, they pronouns. And Lauren is a research assistant professor in the Department of Medical Social Sciences and the associate director of the EDIT program in the Institute for Sexual and Gender Minority Health and Wellbeing at Northwestern University. She identifies as bisexual, aspectrum, and demigender. I have trouble saying that word, Lauren. So when you come on, just say it correctly. And has 18 years of experience leading LGBTQ and bisexual organizations in higher educational and community settings. Scientifically, they investigate the epidemiology of chronic physical health conditions among sexual and gender minorities, also known as SGM, populations, and strive to empower SGM community advocates to create evidence-informed SGM health policy. Welcome, Lauren.
Thank you so much, Kim, for that really friendly introduction. And I pronounce it demigender, so just to say that. And I really feel humbled to be on this panel today. The main focus of my presentation is going to come more from my experience as a researcher who does a lot to try to both get data capture for SOGI added to existing systems, and then also analyzes that data, including outcomes data. And so I'm going to talk about the different types of data collection that exist where SOGI can be added and what that means in terms of moving forward advocacy efforts to understand the impact of COVID-19 on sexual and gender minority populations. So with that, hopefully you can all see the slides. Great. So just an overview, I think I just went through this. And I'm also going to end on a note of implementation challenges, which Laura will build upon in the next panel presentation, and also that Tammy touched on. So this right here, though, is a part of what Scout was talking about in the introduction to this panel. And I think, Scout, you did an amazing job of, I couldn't think of a better way to preview this slide, which is about the birthist in a lot of ways. So this is Healthy People 2020. So Healthy People 2030 is coming out and everything, but I really appreciated the Healthy People 2020 focus in the importance of having existing data systems ask questions about sex, sexual orientation, and gender identity. And so Healthy People 2020 had some of its objectives, adding the number of data systems that use standardized or harmonized measures. So that's another thing. You know, there are a number of ways that you can ask SOGI questions, and to be able to collapse data, you know, we need to also understand what harmonizing those different questions looks like to get a big picture of public health. So you can see that language too in the Healthy People objectives. And then specifically, these objectives had called out in the past the need to increase the number of states that actually ask SOGI questions in their birthist data sets. And so that is something that people here worked hard on, including, I don't know if I should say, but Scout, you worked super hard on this data advocacy piece nationally, and your work is a big part of why we've seen these changes with the number of states increasing over time asking these questions. And so kudos to you, to the National LGBT Cancer Center, and to the many other stakeholders and leaders who helped make this change happen. And it is a data advocacy effort. And I think, Tammy, your talk really was outstanding at showing what those processes look like behind the scenes. And it's a struggle to get these questions added. And having questions in place about SOGI is the bedrock and foundation that surveillance builds upon in terms of understanding what the COVID's impact is and any other health condition, health behavior, et cetera, impacting SGM populations. And so the importance of having these foundations present cannot be overstated. Next up, I just was basically summarizing this slide, but also from here, I want to highlight that research is often an important piece of what informs policy change and policy advocacy efforts, because, you know, if you take a case, you know, you say, I want a bill to go into the legislature, I want this health agency to make policy change, I want you to add SOGI questions to your existing surveillance, the first question you're going to get is why and what's the impact, and how do you know the impact? And so that's also what data advocacy does, is gives you the ability to answer those questions that are really foundational when you're trying to make change. And I also want to highlight the importance of community, because if data in the wrong hands or used for the wrong purpose can also be quite harmful if it's framed in the wrong way, et cetera. And so it's important that community stewards are the ones leading the way and sharing the results of analyses that are going to be possible to describe the health and health disparities in LGBTQ populations once we have the ability to know what that data is, because we ask the question. Over time, the number of sources asking these questions is increasing. We saw that with BRFIS, we're seeing it with the COVID response, we're seeing it right now, even NIH is adding to their existing cardiovascular cohorts or other longitudinal cohorts, they're adding questions of sexual orientation and gender identity. I think we should be seeing a push. One of the other things that you'll see, like in randomized clinical trials, like we should just be adding these measures everywhere. And as the message gets out more and more, we're seeing that happen. And I also want to just say that we're seeing it in federal legislation too, or we have historically, and maybe we will again see that moving forward, that federal government, whether at the administrative or the executive levels, or even in the congressional and legislative spaces, we're seeing bills that have come out to encourage SOGI data capture, to encourage research in the health of SGM populations. This particular point is from the 21st Century Cures Act, and it was used to help support the recognition and funding, or more like the funding of SGM health research at NIH, and to have the Sexual and Gender Minority Research Office there get a boost in terms of the importance of the work that office is doing. Right, so next up, I have just a few data sources that you'll see on the left, and then I'll move forward to the slide. You'll see how these different data sources are going to connect to data advocacy efforts and the role that different types of studies can play in telling the story of the impact of COVID-19 on sexual and gender minority populations. So what you'll see here first, near the top of this table, is data sources like surveys that are convenient samples that would be focused on collecting data from sexual and gender minorities, as well as people with HIV. Underneath that, you'll see electronic medical records. That's already been touched on a lot, because you need EMR data to have outcomes data typically. Either that, or you need to be asking the questions in surveys. That could be a community survey, or you see later on here, federal epidemiologic surveys, surveillance surveys, or cohort or RCTs, et cetera. Then you also see the pop-up testing sites that were mentioned, like drive-through COVID testing. There's also contact tracing. These 5 data sources in an emergency situation are going to be the ones that are going to give like the fastest snapshot of what the impact of the pandemic looks like at a given moment. And so I say that because federal epidemiologic surveillance surveys like BRFIS or YRBS are asked, in the case of BRFIS annually, in the case of YRBS every other year. And so that's slow. And the ability to get questions added to those existing data sources that ask these questions of BRFIS asks questions just under 500,000 people every year. YRBS, the national is 15,000, but then if you combine all the state and local jurisdictions, it's maybe a couple 100,000 youth who are asked these questions. And so that's slow, but they're nationally representative, and they give a kind of a snapshot, therefore, of the national level effect of COVID, and then we can look at it for SGM populations, but it's not going to be a pandemic surveillance support reporting snapshot that you get from these top 5 rows, if that makes sense. Also, you see underneath here cohort studies. So NIH has done a big push. The National Institutes of Health, which is a major government agency that studies the health of human populations, they have done big pushes recently to get money out about addressing the impact of COVID-19 on the health in the United States. And so what we're seeing is cohorts that have been in some cases ongoing for 35, even Framingham has been ongoing for 70 years, are adding these questions. And so you can look, what that does is over time, within the same group of people, you can see how people's health behaviors and comorbidities like diagnoses for diabetes, for asthma, et cetera, are going to longitudinally affect whether or not they are getting COVID, what the morbidity of COVID looks like, mortality, all of that. So we can start to get really high quality data, but again, very slowly. It's not a pandemic response that we're going to be able to, it's not going to in real time capture this. And then that, though, is a really rich source of data that will help us better understand the mechanisms and the underlying conditions that are affecting the health of sexual and gender minority populations to the extent that those questions are asked. And that's still an evolving area. It's getting sexual orientation, sex, and gender identity questions asked in these cohort studies. That's largely a cusp of where we're at right now in terms of moving forward with adding SOGI data capture in existing federal research cohorts and infrastructure. There's also randomized clinical trials. You've probably seen a bunch of news about that in terms of the vaccine or about other drugs that were being tested, how effective they might be against COVID, like remdesivir, for example, or dexamethasone. Probably did that right, but anyway, we're looking at these drugs. Are they effective? Usually you're going to be conducting, and there's a lot of ways you can do that, but the most rigorous way would be a randomized controlled trial. But a lot of those don't necessarily ask sexual orientation, sex, and gender identity. And so we are missing out on the opportunity to understand, therefore, if treatments are effective. We can see if a treatment is effective for everyone in that trial, but then we want to see, is it effective for, how effective is it for sexual and gender minorities? And that would be not because of some underlying biological factor, but, we could be looking at our SGM people dropping out more. Are they less likely to be able to take the medication consistently? Like, we can start to look at things like that from trial data. And then lastly, I have convenience. I have it twice, I guess. Sorry about that. But this right here is like survey data from convenient samples of SGM populations. Why I put that in there maybe twice is because this is the type of data capture that's going to center getting LGBTQ people, right? And we're going to have a majority-minority sample then. And so then you can look within subpopulations of sexual and gender minority folks and see what different risk factors look like. What are people willing to be tested for COVID? Are they willing? Have they been tested for COVID? Have they experienced COVID symptoms? And Dr. Gregory Phillips and myself, so Dr. Gregory Phillips is on right now, is on the call as well. We've gotten a survey out and has 1,000 people who've answered questions like this, that's in SGM people and people with HIV, and we're analyzing the results now. So if you want to understand quickly in a pandemic what's going on in SGM communities, that's something you can do. But the thing with that is that it's not going to be nationally representative. We're not going to know how, therefore, what this will look like in comparison to, say, BRFIS or YRBS analyses. Also, I think, Scout, I've seen a number of these surveys. I think the National LGBT Cancer Network has put a lot of stuff out. I don't know if you've done one yourselves, but if there are other folks here who have done those types of surveys, I'd love if you put it in the chat, because this is going to be a way that we connect to understand how we can get the fast data now that gives us a picture about the impact of COVID and sexual and gender minority populations. So I just wrote that out in this table for people's reference. The slides will be made publicly available after the conversation as well as a quick reference guide. So the other thing that can be done, Scout, to the thing you were saying about not having headlines because we don't have the data, that's absolutely where we're at, but that doesn't mean we can't write opinion pieces. And so, yeah, we can, and that's something that people here are great at. This is just an example of an editorial that was led by Gregory, and I'm senior author on from the edit team. A lot of our very talented team members are authors on that too. that makes this point that we need to get this data to understand the impact of COVID-19 and sexual and gender minority population. And you can see this little infographic that was made to talk about what we need to be doing comprehensively in health systems as well as within data advocacy efforts to make this happen, including training health center staff to serve LGBTQ patients, the data capture, which is next. And then with this being able to, like, if you've got SOGI data capture and COVID data in electronic medical record system, if you've got the capacity to analyze that data, that's when I think that's a quick way we can start to get papers out. And that's also the direction that a lot of work, I think, is heading. We also highlight here that this is what we're talking about is a pandemic response. And so that means that emergency preparedness plans need to actually address adding SOGI data capture in emergency circumstances. And so that's something we talk about in the editorial. And then just also the importance of speaking out about the importance of this work about data advocacy and health research that centers the lives and health outcomes of LGBTQIA people. So with that, I think really, so here's the case for why we need to do this, but then implementation is another topic, right? And implementation is hard because it's change, and change is hard. And if you can get through to people that this is important now, we actually have to do this, then the question is, what does that look like, and how do we move forward, and how do we learn to do it better? And I think that's the note, Tammy, that you were ending on. Scout, I also heard you talking about that, and I know that next up, Laura's going to do a fantastic job about giving one example of what that looks like at Howard Brown Health. So with that, thank you.
Thank you, Lauren, so much for that breakdown of the different data sources and both their strengths and challenges. And you have certainly built the case. If nobody believes it yet, I mean, they need to talk to you again, because I think you laid it all out pretty well. Next up is our final panelist, and then we're going to open it up for Q&A. And I know some folks have been putting questions in the chat, and some of those questions are being answered, so that's great. But if you have any other questions, let's keep them going. I think there's a lot of good dialogue that's coming out of this discussion. So our final panelist is Laura Russi, who uses she, her pronouns and is the Director of Data Evaluation and Epidemiology at Howard Brown Health in Chicago, one of the nation's largest LGBTQ healthcare organizations. She has a Master of Science degree in Infectious Disease Epidemiology from Johns Hopkins Bloomberg School of Public Health, with an emphasis on HIV and hepatitis infections. In her current role at Howard Brown, Laura oversees the usage of much of the operational and research data for the agency, and is passionate about using data to improve patient-centered care. You are up, Laura.
Great, thank you. Thanks so much for having me here. I've already learned so much from the other panelists. So again, I'm Laura, use she, her pronouns, and I am speaking in place of Dr. Green today. So given the recent trends in Chicago, Dr. Green is doing the important work on the front lines. So I will be covering a little bit about Howard Brown's COVID testing, just to level set there, our experience with SOGI data collection during this time, and then driving home the same point everyone else is making, the importance of this data. So Howard Brown has done almost 45,000 tests so far, and we've identified over 5,000 positive tests. And I say this just to say that the volume of testing and volume of the positives that we found has made some of the other portions of our response a little bit difficult at times. And so this is the reality that some F2HCs like us are facing in Chicago. And we have conducted 2.8% of all the tests in Chicago, but we've identified 4.1% of the positives. We're really proud of that. We think that that means that we're in the communities that need it most. And Howard Brown specifically is really well known in Chicago for being an affirming and welcoming place for LGBTQ health. So it stands to reason that, at least a portion of these tests that we're providing and the positives that we're identifying are concentrated among LGBTQ folks. But you'll see that we have had trouble collecting that data, even though we like to think of ourselves as really, really pioneers in that. And so we'll talk a little bit more about some of those difficulties. So here on the left is the COVID testing and positivity by gender. And it looks almost exclusively like cis men and cis women. And we have some trans men, trans women, gender queer, non-conforming folks, but what actually is hidden in a lot of this data is that we just don't have any of the nuance of the questions that we should be asking. So you'll see here that 72% of the people we're testing for COVID are new patients, and only 28% are established patients. So we have great SOGI data on our established patients, and we're really proud of that. But among the new patients, given the volume and just some of the difficulties, again, that we'll talk about, we are often stuck collecting some of the bare minimum, and our EMR only requires that we, require meaning like to be able to save the chart, only requires legal sex. It doesn't require sex assigned at birth. It doesn't require gender identity. It doesn't require orientation. So what's hidden in a lot of this data likely is people that appear in the data that I'm processing to look as though they're cisgender, and they're probably not, if we had to take a wild guess at it. Again, these are recent trends at Howard Brown's data. So you can just see that this big spike in the number of positives, as well as the percent positive, meaning this isn't just an increase in testing. There is an increase in cases going on. And I think Scout had mentioned this, that this is the time then that we need to act. Like we missed our chance the first wave. We've got a second wave coming up, and we really, really need to take the time to address the issues at the clinic level, at the city level, at the state level, and everywhere in between. So this is where Howard Brown is testing. These are patient zip codes. So just to show that we're testing all over, but primarily a lot of testing on the north side and the west side right now. As well as this is our percent positive, so really concentrated over on our west side locations. So this is the complicated workflow that a patient would experience when they come to one of our testing tents at one of our many locations. And so you can see that this doesn't necessarily lend itself really well to robust data collection at every point, and nor should it sometimes. So there's long lines at all of our testing tents, and they are for not just Howard Brown, too, all across the city. And so in order to keep people safe, keep them spaced out distance, like physical distancing. We've got these long lines, this complicated process for everyone to get through everything they need. And so it just creates a lot of bottlenecks, particularly with staffing. So when someone comes and presents for testing, the registration desk only has so much time to collect the data they need. And often what's prioritized is contact information, and then entering the test requisitions correctly so that the test actually gets run by Quest or IDPH, and that can be time consuming. And so for a lot of this everyone's stressed out, it's busy, everyone's wearing PPE, everyone's 6 feet apart. It can be really hard, especially for a new patient who's never been seen by Howard Brown, to fill out a full, complete registration form. So that is really our biggest challenge right now, is just the time and staffing issues of collecting some of this data, while we need to address the hundreds of people that are standing in line for testing. This is a snapshot, and don't worry, this is a test patient, so this is not PHI. This is a snapshot of our Howard Brown custom registration. So just to show that there are lots of things we collect, even just from a custom perspective. So not even everybody collects things like the housing and various like specific demographics and SOGI data. And this let alone doesn't even look at what we have to collect for contact information and insurance and all things like that. So just to show how many data points need to be addressed in a short amount of time. And when we get to the very last one, unfortunately, for our custom demographic fields, we attempt with everyone to collect sex assigned at birth, gender identity, sexual orientation, and their pronouns, but sometimes it's not feasible. The timing just doesn't allow for it. So just to reiterate, it's just timing, the volume of people and the time that we have with them makes it really challenging to get some of this data. So they have to prioritize certain data points. Safety first for everyone means no paper registrations while people are standing in line, things like that. Again, 72% of these are new patients, so it's really hard to collect a lot of data on them. A lot of the populations that we're working with are hesitant to share a lot of these details from maybe past experience, or they don't know who we are, or blah, 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 and that is totally valid. And attempts that we've had at collecting the data on the back end after the fact through nursing and contact tracing has also been a little challenging, just given the volume of phone calls that are coming in and going out. And there's so many urgent needs that these patients have sometimes, that to get them food, to get them rental assistance, to make sure they're safe in their homes, and to answer all the questions they have and how worried they are about things, again, just presents a lot of challenge for data collection and then like recording it in the EMR and all the other things that these people have to do. Some successes that we've had, so we have implemented an app called Helpvana that people can register themselves on their phone. Although this does come with difficulties that not everybody has a phone they can download an app on. At long lines and at testing locations, we can't really coach everybody through how to download an app and fill it out. And the contact tracing interviews are a great place to gain patients' trust. But again, those interviews are actually really meant for a different purpose. And so those can be very lengthy, and collecting information on all the contacts doesn't lend itself to getting great SOGI data in those instances either. I have been sending out weekly QA reports to a team that is really gung-ho about trying to call and get some of this data. So we do have buy-in from staff, particularly from top down. Everyone knows this is important and they really want to try and help. And collaboration with our community partners has helped a lot. So particularly with Project Beta and Task Force, we've collaborated with them to set up testing tents, and people know them in the community. So they trust them, and they trust that if they're working with us, they can probably trust us. So they are willing to work with us a little bit and share more data. We did a big kick of hiring a lot of Spanish-speaking staff, which has helped quite a bit. And we are collaborating with CDPH now on implementing the contact tracing interviews that will be used citywide. And so we've made it, blanket requirement. The SOGI data is on those interviews. So that's good. We'll see how much of it is collected, but it's on there. So it's a success. So again, even if we collect this data, it often gets lost. So we heard that from some of the previous speakers, that these things aren't harmonized and they don't always transfer around to each other. Nobody knows where to go for the data half the time. So this is a snapshot from the city's dashboard. And you can see that they've got gender as a binary, female and male. And so when we report our data to the city, we have to collapse our data into the binary. We don't have anywhere to put our data in any more nuanced way. And even the city, so in their own publication for 2018, they acknowledge that 7.5% of the city is LGBTQ, but they aren't collecting the data or giving us a place to put that data. And so that makes it really, really difficult then for us to start planning ahead to take higher level data and to drill down and to make plans for ourselves and our communities when we can't drill down to anything past the binary. It's the same for IDPH, binary. So just to drive it all home again, that we just really need this data. So we know, and this is great, and we know that it's affecting Black and Latinx communities, people in poverty, older adults, I could go on, but what we don't know are the intersectionalities within that. So we know historically that LGBTQ folks with these multiple identities can have even more stark health disparities, but we can't figure that out from the data that we have right now. But there's no reason to believe that it's not there. we know that they have higher prevalence, LGBTQ folks have higher prevalence of a lot of chronic disorders that we know can lead to worse outcomes, as well as tobacco use, you heard from Scout. And there's a lot, we always know all this, but we don't have the data right now for COVID that mental health issues can be very pressing. There can be more misuse of substances. There can be more experiences of violence in the places they live. And we don't have the data on monitoring it and to even then begin to be able to come up with ways to address it for LGBTQ folks that are experiencing all of these additional issues while they're in isolation. And I like to end with this saying that I say LGBTQ through this whole thing, but there are differences within each of those letters. Asthma, tobacco, all those things are different on all those. So we need as nuanced and detailed data as we can get so that we can actually start addressing COVID in this community. So that is it. Thank you for having me.
Thank you, Laura, for that very interesting presentation about the challenges of implementation and how even when you're trying to collect the data, you're bumping up against some existing structures that also need to be dealt with. And you also pointed out the urgency of now, right, as we enter this second wave, unfortunately. So at this point, first of all, let us thank our panelists for sharing their insights and information. As we know, we could do a full day or two or more on this topic. So I want to thank the panelists for whittling down so much information into this format, kind of like when we had this, you have to send the data to the city, right? But you pointed out some really, really important things. And now we're going to move to the formal Q&A. As I mentioned, I know folks are asking and answering questions in the chat. But one of my colleagues from Howard Brown, I don't know if it's Tim or Andy. Is it you, Andy?
It's me.
All right, Andy is gonna sort of moderate this area and ask the questions. And Andy is the Vice President for the Center of Education, Research, and Advocacy at Howard Brown.
Thanks, Kim. So far, we have one question in the chat that's been answered a little bit, but there may be others who have additional feedback or observations. So the first question is, are data for minors treated any differently given that forms are completed by parents, guardians who may not know the patient's true sexual orientation or gender identity, but may assume cisgender and heterosexual?
I think one of the things I said was we're not sure at our end, so I'm meeting with the state representatives around what they see related to their data. So I'd be perfectly willing to ask them to see how it's happening. But I think even what Laura, or what was being talked about related to how Howard Brown is collecting it, wildly different than what we're seeing in Rhode Island. Like, you go through a state portal and answer a very small number of questions, and then you get your test scheduled. So you can't get to scheduling your test until you've answered these questions. So, just your mileage may vary in every different state's or every different, agency's approach to this is really something we're dealing with.
Great. If there isn't anything else to add, I'll go on to the second question. Is the barrier with binary reporting systems caused by the software contractor or the city itself? Have we talked to Lori's people about this?
I don't know if we talked to Lori's people. That would be for the advocacy folks from Howard Brown, maybe. I actually don't know where the root cause of this is. I mean, so sometimes so I've made progress with the city. I also have automated our MORB reporting for gonorrhea and chlamydia, and I made progress on that front to add a couple more data points, and that was hard, but we won, and we've made some progress with some other things. So it might just be that this, like Lauren was mentioning, like this is it's a pandemic response. This is like brand new pop-up system. And so I'm not exactly sure where we would start, to be honest. I don't know if the advocacy folks have a better idea with who to talk to under Lori.
Hi, this is Tim Wang. I'm the Director of Policy and Advocacy at Howard Brown. I also don't know if it's an issue with the city or if it's an issue with the software, but I think that's a great question to get clarification on. So I think that Laura, you and I, or the advocacy team at Howard Brown can definitely be doing some outreach to figure out where that little snag is.
Mm-hmm.
Great, thank you. Next question, and there's a comment. Thank you, this is great information. Thanks, Chris. Our electronic medical record does not require sexual orientation or gender identity either, which makes gathering information difficult. And we have a lot of missing data. Do you have any words of advice for effective ways to encourage healthcare professionals on the ground who are testing people for COVID-19 to add and then collect sexual orientation and gender identity information?
I've talked with a lot of hospitals that have added it. And I think uniformly what you find is when you're a health system and you're trying to change this to add SOGI data to your any kind of intake, and of course, getting a test is one type of intake. It's not small, it's a big process. It requires a lot of patience. You have to kind of advocate all the way up the chain. And then the chain then usually has to create systems change, like, groups, have to be trainings. Mount Sinai just went through this in New York City, and it took like a year for them to prepare to finally flip the switch. Moffitt's a big cancer center that's been doing it for a while too, and described something very similar. So I wish we could tell you that there was a great shortcut, but I haven't heard of any. I mean, the FQHCs which is like Howard Brown is an FQHC, federally qualified health center, which are the safety net, like smaller than hospitals, health centers, are required to collect it because of HRSA. So, which is a federal administration that just says, please collect it, the end. We'll give you money only if you collect it. So we do know that actually one of the more successful strategies for doing this is just requiring data collection. Like right now, CDC is doing listening sessions with LGBT groups and LGBTQ plus groups. And it could be that people here have been asked to talk to CDC. So one of the things that I would certainly recommend is whenever we can, if we can get to the point where the federal government just says, no, you have to collect it. We got in through healthcare reform. The way we got all these software programs changed to include SOGI options was through meaningful use with a part of healthcare reform where it required it. But that was a step short from saying now collect the data too. So honestly, if we really wanted kind of a simple answer for how it could happen, the simplest answer was when the federal government just said, you need to give us the data, then the FQHCs all fell in line. But other than that, there's been really long processes. But it doesn't mean you shouldn't keep pushing for it. I really do encourage you to push for it. I'm just saying it might not be really soon.
Yeah, I would echo that. And we're about to go into, starting that process at Northwestern right now. And so in March of 2019, Northwestern had their EPIC updated systems go live that allowed for the data capture. And they announced that was going live, but there has been a lower percentage of uptake. And so now we're working with using a quality-based route to address actually training providers, and also we're talking about letting patients know that they can complete the information in my chart too. And it's, I think, the best possible scenario if patients are completing the data themselves versus a provider. I think this was in the chat too, like providers like checking it box or having other people report on behalf of someone. And so but I anticipate it's going to be a long process, and it requires also I think one thing that can be super helpful is building a champions network. Like finding a group of people, like if you know that your hospital or your health system is organized and that there's like 50 units, you need at least 50 champions, and it helps if they're providers who are speaking to their peers and being able to train about what this looks like, what it means, and then also how to look at and use the data. But yeah, it's not a short or simple process. It's a systems change process.
I could say one more thing related to that. I didn't work with policymakers or legislators very much before, and it's really come to my awareness that a lot of them are not understanding how important data collection is to us. So for all these agencies, organizations, Equality Federation members, anybody who talks to policymakers, anybody who talks to legislators of any hue and stripe, please make sure they understand that data collection won't just help us with COVID. Data collection will unleash a fire hose of sexual and gender minority health data that is going to give us our first cancer outcome data. It just goes on and on and on. Our world will wildly change once data collection, especially on electronic health records, is universally adopted. So we need to tell those policymakers it makes a difference to us.
I wanted to echo what Scout just said, that I think people don't necessarily know that it needs to be collected. So just telling them is a good start. I've had success in the past for different data collection barriers, really doing a quick emphasis on the public health impact. I think that helps bring it home for people, like, oh, right, these are communities and things I should pay attention to. Just a gentle reminder of the impact that they could have if they start collecting the data. And I think the final thing I want to say was providing some training to give them the right words to do the data collection would also be helpful, I think. Some people aren't confident. I mean, I didn't go to medical school, but I've heard that medical schools aren't great always at training people on how to talk about these things. So, giving people a little bit of training and so they feel competent and equipped to collect the data could also be helpful.
Great, thank you so much. And the questions are still coming in. That's a nice pivot to the next question. Is there something that kind of should be done at the federal level, administratively or legislatively, to facilitate, encourage, force more sexual orientation, gender identity, COVID-related data?
I might work at the federal level more than some do related to data collection. And yeah, CDC could ask for it. CDC doesn't even allow you to report sexual orientation and gender identity on their case report, on their test results form. And I noticed the form has just enough space to add those right in the center, but they don't even have it there. So yeah, we could definitely move this with CDC. There also have been a couple different data collection bills that have been introduced related to SOGI data collection at the federal level. And honestly, lots could hinge on Georgia, because none of those things will likely go forward unless Democrats end up controlling House, Senate, and the executive branch. But if that is the case, we may have a small window of opportunity to actually potentially move one of those. But in addition, there's a lot of bills going forward now that have to do with data collection. There was a lot of data modernization money that was already released to CDC, and it did not mention SOGI at all. So that means they're starting to rebuild the towers related to data collection, and we're still outside the city, or whatever we want our analogy to be. And so that unfortunately is going to, leave us at even more of a disadvantage. So data collection is just on everybody's tongue because of COVID. So we need to talk to, our allies, our legislators, anybody who will listen about how it's ridiculous that we're ceding the ground to be ignored for decades if we do not seize this moment and change it for us quickly.
I think another thing that can be done, so I agree that legislatively, like, we want to do everything we can, and Tammy talked about this too, like there was like this idea, well, maybe we shouldn't push for codification, right? Codification. And then Tammy, your response was, no, we need to be pushing for this. It's important that we do this because it's more permanent that way. I just think that I wanted to say that because there's multiple ways, and this is something that's ongoing with discussions with a group in Illinois too about what to do here to get this moving forward. Social data capture in Illinois, COVID-19 pandemic response moving forward. What route do we take? Because is it going to be administrative? Is it going to be legislative? Is it going to be a mix of trying to do those things? And I think at the federal level too, it can be, let's start with executive administrative agencies, especially if we do, like wherever we have control in the government, let's try to start there. And often administrative change and executive administrative agencies, typically that falls underneath the president. And so then if the president and if the White House is interested in enacting some changes like this, you can get an executive order, you can get something through HHS, you can get, which is another, sorry for all the acronyms, Department of Health and Human Services. If that person is, appointed and is friendly to what the White House is interested in doing, they can issue regulations administratively or guidance, et cetera, that encourages the collection of this type of data within the federal government. And so you can do that quickly, but it's less permanent, as we actually witnessed in the last 5 years of what's going on with some of the things that were put forward underneath President Obama's administration, then being shifted under President Trump's administration, and we'll see what happens moving forward, what I will say.
Thank you so much. So the next question is for anyone who is attending. Is there someone still on the call who can speak to the California or Pennsylvania experience? Is collection happening right now per their regulations and laws? And if so, what is compliance like from hospitals and federally qualified health centers?
I don't think we ever had anybody on from Pennsylvania. I just spoke about it. So I don't know. I have a person I'm supposed to contact related to it. And I don't know about California.
Okay, great. We can also get that question to Tammy, who needed to leave early. And so thank you for that question. We'll go ahead then and move on to the next one. There have been a number of points made about the need for education around the need for this data. Has there been a move to coordinate education and outreach work for this issue across states, especially because that education is needed across the board to policymakers, community members, and healthcare providers? Great question.
I think I'm actually only on this because I made a little video for Equality Federation members being like, pay attention to data collection, please. These are the reasons why. And I think that got over to someone in Illinois. But I actually didn't get much of any response, from Equality Federation members themselves. So I'm just really excited that people are starting to pay more attention. I would love it if we get something like that. I don't think its time is quite yet, but I still think that this increased level of attention we're getting to it in the different states. New Jersey also introduced legislation around it, didn't end up getting passed, but they tried. It means it might be data collection's moment. So I'm really hoping we could be on a cusp of starting to meet and gather and convene and interact more around national approaches to this. Yay. Oh yeah, right. Aaron heard me exactly. Right.
Great. And then we have an observation: more robust data collection is more responsive public policy. So thanks for that. Totally agree.
I agree with that. And I also wanted to say that it's also like the community. So I feel like in my talk, I positioned it like community advocacy important, as data is important, but didn't do enough connecting the two, because there are parts of community stakeholders who are data collectors and data advocates. And like we're seeing it within federally qualified health centers. We're seeing it with organizations that analyze data and disseminate data-based reports that are about LGBTQ communities and LGBTQ health. But we're not necessarily seeing the bridging and relationship formation between the advocacy arm of things and like the data arm. And it's like how do we form community stakeholder community research partnerships. It's kind of a strange thing to ask. I'm used to asking that question and answering that question in the context of academic community partnerships, because then like the academia is positioned as research, community is positioned as more stakeholder advocacy. But this is a little different. It's like community partnerships to talk about data advocacy. And I think that might have also been sort of the spirit of that question, like the education is needed across the board. But like, I think there are like grant mechanisms and there's like lots of investment in trying to figure out how to do this in like the academic community partnerships world. But I haven't seen anything like that that's putting aside time and resources to do that in these broader partnerships that are like community partnerships or community health center partnerships, like community stakeholder, like SAGE and Howard Brown and AFC and the Equality Federation organizations. Like I haven't seen like mechanisms designed to foster community data advocacy partnerships. And I think that could be something that could be helpful. But I don't know if anything like that exists elsewhere or if other people have seen that.
Great, thank you. Those are all of the questions in the chat. We have time for a couple more if folks have additional questions. And while I'm waiting, maybe I'll just jump in with one here. We've talked about the different barriers to implementation. How would you prioritize those barriers? What do you think the biggest barriers are to implementing SOGI data collection?
For Howard Brown.
Sorry.
No, go ahead, Scott.
One word. It was just the word will. There's no will to actually implement it. That's our biggest barrier. Then beyond that, you can go ahead.
Yeah, well, and I think from a large system, it's like there aren't the drop downs. Like there isn't a place to put the data sometimes. That's an issue. For Howard Brown though, for us it's staffing. It's the time that is needed to collect that information. And those people are standing for like hours in line, and then we've got only a couple people in front of a laptop trying to make sure that their test gets properly sent to IDPH. So it's just time and staffing for us. I don't know how to tackle that. Hire more people.
No, that's great, and underscores the importance of resources to at the community level. So thanks. I'll add another question. Who should we be directing advocacy efforts towards?
So, the feds honestly could make the biggest change for the most states. And if this was carried by Congress, they could make the biggest, fastest change, but in being done, So, but on the other hand, one step below that, Health and Human Services, has done a great job with advocating it through the federally qualified health centers, which is only one small section of health providers. We're going to get new heads of new HHS organizations now that we have an administration change, and some of them could be very friendly. So, HRSA is the HHS organization that has the most to do with healthcare. CDC is the HHS organization that has the most to do with COVID testing. And then actually Center for Medicaid and Medicare are the people who decide what hospitals have to report in order to get Medicaid funding. And since everybody wants it, that's like another hack to get in, that if they say we need it, then suddenly everybody will report it. So kind of those are your options. NIH, it'd be great if they did more on data collection, but their research is valuable and important, but it's not as widespread as healthcare. So those would be the the areas that I would think about prioritizing.
Great, thank you. And we haven't received any more questions in the chat.
I think this is a good time to, oh, look at that. We are right on time, y'all. This is excellent. This has been an amazing conversation. Thank you to our speakers, Scout Tammy Martin, Lauren Beach, and Laura Rusi. I also want to give a shout out to the Howard Brown Health Team for all the behind the scenes work. So Andre Akimov, Andy Baker, who was in front of the camera, Mindy Naveau, and Tim Wang. Thank you all for your help. This event actually comes out of the work of an informal group of organizations and individuals who are concerned about understanding and systematizing the collection of sexual orientation and gender identity data so that we can track the impact of public health policies, conditions, behaviors, and emergencies like COVID-19 and its impact on LGBTQ communities. And we're learning that this is a very complicated type of thing to do, but it is also a very necessary thing to do. We are also planning a second event in early 2021 that will focus more on the nitty-gritty details of the joys and challenges of data collection and what that looks like on the ground. And in the meantime, the video for this event will be available on Howard Brown's YouTube page, or is it a page? It's not a page. Whatever it is, on their YouTube in a few days or so. And if you have any additional questions or concerns, and also if you want to join this working group, as Lauren pointed out, we really need a robust community of stakeholders, researchers, policy folks to do this work and to do it well. So if you want to join that, and again, if you have any additional questions or concern, Tim told me that I could give out his email address. So you should reach out to Tim Wang, and it might be good if you haven't already, Tim, to put your email address in the chat. It's timothyw@howardbrown.org. So thank you all for spending your time with us and for your attention and for your great questions and discussion, and have a wonderful evening. Thank you.
Thanks, everybody. This is great.